My name is Clemons. This is Case Connections Unit 4 for UNE Biochemistry, and it is November 21st, 2024. So starting off, we're going to start off with Case 2. Scenario 1, 9-day-old female patient underwent newborn screening for branched-chain amino acid BCAA, which resulted in positive results. There is no history of any genetic disease, and it includes both sides of the family and older siblings. To start off, in branched-chain amino acid BCAA metabolism, isoleucine, leucine, and valine are first transaminated, removing the ammonia group NH3 from their chemical structure. The amino groups are then catalyzed to the enzyme branched-chain alpha-keto acid dehydrogenase complex, BCAD. A positive BCAD test reveals an increased number of branched-chain amino acids in the blood, potentially due to the lack of functioning BCAD enzyme. No amino acids become essential in this patient with deficiencies, BCAD deficiencies. However, the recommendation is BCAAs be restricted in the diets to prevent buildup of the bloodstream, and also to decrease symptoms such as ketonuria, encephalopathy, and metabolic decompensations. And treatment, vitamins treatment include pyridoxal phosphate B6 and thiamine B1. B6 is required for all transamination reactions. It's the first step in BCAA metabolism, as well as B1. The thiamine is a cofactor for BCAD. It has been found in rare cases that large doses of B1 supplementation may help decrease the symptoms of patients with maple syrup urine disease, which is a disease that is caused by branched-chain amino acid metabolism deficiencies. Our second scenario is a 69-year-old female with a 30-year-old history of lower back pain, considerable joint pain in the hip and shoulders. She also presents with blue-gray pigmented areas of her cartilaginous areas over her ears and aortic stenosis. Based on this patient's presentation, we can determine that the patient most likely has alkaptonuria. This is a genetic protein metabolism disease. We can see here it is in line. It is in the line with the phenylalanine and tyrosine metabolism. We have a deficient enzyme HGD, which is homogentisate 1,2-dioxygenase. The lack of this enzyme results in buildup of homogentisic acid, resulting in ochronosis, which is the buildup of that benzenic acetate in both extracellular and intracellular connective tissue, and this buildup results in the presentation that we're seeing from the patient, including that blue-gray pigmented area over her ears and the aortic stenosis, which is buildup of that benzenic acetate on her aortic valve. Phenylalanine is converted to tyrosine via phenylalanine hydroxylase, so we're both receiving ample enough of phenylalanine and tyrosine, so we do not have a new essential amino acid that comes into play. However, we can somehow treat this process that's occurring. There is no known effective treatment for alkaptonuria. However, it is noted that vitamin C supplementation may be beneficial due to its ability to reduce the conversion of homogentisic acid to benzenic acetate, as well as maybe a low protein diet to minimize tyrosine production and alkapton buildup. Scenario 3 presents with a 4-day-old infant born at a healthy birth weight and normal pregnancy. The significance of the newborn screening is underscored as it revealed as abnormal phenylalanine levels of 6.6 with a standard of 1.2 international units per deciliter. Based on the patient's laboratory results, PKU, which is phenylketonuria, can be diagnosed. PKU is identified days after birth via blood analysis. It can be found in infants free of symptoms born at adequate birth weights. PKU is most likely a gene mutation resulting in a deficiency of the enzyme phenylalanine hydroxylase, PAH. PAH is responsible for metabolizing the essential amino acid phenylalanine to tyrosine. If left untreated, PKU can lead to severe intellectual disability and other health problems. Deficiency in the PAH enzyme results in decreased amounts of tyrosine, making tyrosine an essential amino acid that must be provided via the diet, such as cheese, soybeans, pork, fish, eggs, and grain. PAH is enzyme functionality is dependent on tetrahydrobiopterin, which is BH4, as we can see here in this image. BH4 supplementation, particularly through synthetic oral formulations such as seroprotein dihydrochloride, can decrease phenylalanine levels and increase tyrosine, and offers a ray of hope in the treatment of PKU. Our next case is case 1. We're presented with a newborn girl presumed healthy at birth who develops approximately 24 hours after birth lethargy, hypothermia, and apnea. Lab results reveal an ammonia of 314 milligrams per deciliter, which increases rapidly to 600 milligrams per deciliter. So ammonia transfer is an essential biomedical process to remove excess nitrogen from the body. In the patient above, we recognize ammonia's harmful effects. In the liver amino acids, the first step, they undergo transamination, which provides the nitrogen group and transfers it which moves the nitrogen group onto an alpha keto acid. One example would be aspartate. Aspartate is transaminated with alpha ketoglutarate via the enzyme aspartate aminotransferase. The nitrogen group is removed from aspartate, which produces oxaloacetate. That nitrogen group is placed onto alpha ketoglutarate, which produces glutamate. Peroxidyl phosphate, B6, as we talked about above, is a necessarily cofactor for transamination reactions. The second step of this process is through trans deamination, so oxidative deamination via the enzyme glutamate dehydrogenase. Glutamate's ammonia group is then removed to produce alpha ketoglutarate. This reaction requires NAD plus and NADP plus, either or. Is a reversible reaction, and the reversible portion of the reaction requires NADH or NADPH. Glutamate. So in peripheral tissues, extra ammonia can be fixed to glutamate to increase ammonia movement to the liver. Glutamate synthase fixes nitrogen along with two hydrogens powered by ATP to produce glutamine. Glutamine can then travel to the liver through the bloodstream, and once in the liver, ammonia can be unloaded from the glutamine via glutaminase and water. Nitrogen transport is connected through gluconeogenesis to the glucose-alanine cycle. In peripheral tissues, amino acid breakdown through either catabolism or transamination of pyruvate um, as a byproduct of a glycolysis, can create alanine. That alanine can move through the bloodstream into the liver, where transamination occurs, producing pyruvate and glutamate. Glutamate can then be converted to urea, where it can then go through the urea cycle, as well as the pyruvate can then travel to the pyruvate can be converted to glucose via gluconeogenesis in the liver and then be shuttled out to the peripheral tissues to be used for glycolysis. Further analysis of this patient shows elevated uric acid and low to normal levels of plasma citrulline. In the urea cycle, ornithine transcarbamylase, OTC, is the enzyme needed for citrulline production. A deficiency in this enzyme would cause carbonyl phosphate and ornithine buildup, the two required reactants for OTC, in that OTC enzyme. Carbamoyl phosphate builds up in the mitochondria, can spill over into the cytoplasm. This can, in turn, increase pyrimidine metabolism and consequently increase the levels of uric acid because it's intermediate pathway. Diagnostic markers of OTC deficiency include markedly elevated uric acid, ammonia, and low to normal levels of citrulline. Secondarily, arginine lyase could be a deficient enzyme in the urea cycle. Arginine lyase cleaves arginine to urea and ornithine. Arginine activates N-acylglutamate, the activator for carbamoyl phosphate synthase, CPS1. Increased levels of carbamoyl phosphate can increase levels of uric acid. Through this process, we can see normal levels of citrulline and increased ammonia levels due to the accumulation of urea. The least likely deficient enzyme based on this present lab result would be CPS1. However, in deficient CPS1, we would expect low levels of uric acid as well as low levels of citrulline due to the lack of downstream products in the urea cycle. Due to the defect in the urea cycle caused by the OTC enzyme, we can expect a possible deficiency in the non-essential amino acid arginine. This amino acid will therefore become essential and will need to be provided in the diet. Thank you for this time. It's been a great time in this class, and I appreciate everything. Thank you.